So I guess I'll just share from my own experience as a therapist, which happy to hear anyone chime in if this matches their experience as well. I guess I'll speak specifically, first of all, about psychiatrists. I know that sometimes when I reach out to psychiatrists, it works when it's a psychiatrist who is psychologically minded and interested in the psychology and the emotional and behavioral side of things. And they're actually interested in what I have to say, and it feels like a dialogue where we're going back and forth, and we both feel like we're learning from one another, and kind of together building a conclusion of how to best help this client. Other times, unfortunately, I can't even reach the psychiatrist, and if I do reach them, then they're more interested in just sort of like telling me about medication, and like, okay, what else do you want to know from me? And then it goes less well. So that's been my experience, and I'm wondering if I'm curious to hear, first of all, from the psychiatrist here, what in your experience makes a good collaboration with a therapist, and what separates also good from excellent collaboration?
Yaakov, I'm going to let you start off.
Are you sure? All right. So I think the most important thing to say is stop, collaborate, and listen. It's holding. It's very important to keep in mind that we can only be a team if you're bringing something to the table. So I want to just point out that you collaborate very closely with your colleague because you've known each other for a very long time. You're co-located and you trust each other. And the reason that I know that you trust Shmuel is because you discussed his credentials, and he has significant credentials. He is a licensed clinician. He spent extra time training after that. He does ongoing training. He's in supervision. I believe that you have very similar credentials. You are a licensed clinician. You've done very significant training. You have ongoing training. You have supervision. So I think that as a doctor, we are quite aware of what it takes to become an expert in the field. And there are many good-meaning people, well-meaning people, folks that want to help, but they're in the beginning of their careers and they'd be better served in a academic training program before they go out and start charging 500 shekel a visit in order to pay for meat boards. So it would be very useful for people to do ongoing training, to pay for supervision, to make sure they've actually done licensure before they go out on their own. Shmuel, how long did it take before you sent Rabbi Mordechai out on his own? How many years was he working for you in your clinic before you let him free to ruin people's lives? It's a serious question. How many people have done ongoing training? How many people have seen thousands of patients over many years with ongoing supervision before they go out on their own? So I think that many of us, physicians, who carry significant weight, both in terms of risk and the number of patients that we see, are wary about collaborating with folks who haven't paid their dues. And I think it's very special that you're running this conference, not only because it allows me to try out a number of new jokes, but also because it allows folks who want to gain experience and who want to continue to learn to know about what's at the cutting edge of the field and to be aware of the other trainings that you and your colleagues offer. I'll pass. Go ahead.
It sounds like what you're saying, if I'm understanding you correctly, is that as a psychiatrist, when you get a call from a therapist and you don't know who the person is, it's, well, do I even want to collaborate with this person? How would you gauge, let's say in that first phone call, how would you gauge your impression, whether this is somebody that you want to play ball with or somebody who it's like, oh God, one of these?
That's a good question, Reb Sachi. And I think specifically here, it's important to make sure that people are both aware of evidence-based practices and aren't just IFS junkies. It's also important to ensure that people are familiar with the community and are able to provide culturally sensitive care. So understanding both what happens in the Welt is critical in order to understand what people are going through and to have the cultural context. Similarly, a young guy who decides he's going to show up at the Mir to learn for a few years before he gets married and decides he's also going to paskin taharas is ill-equipped to shoulder the weight of kares. And lahavdil, some nice 23-year-old kid that paid for an online degree and somehow finagled his shver to pay for it, is ill-equipped to deal with people who have risk factors for significantly dangerous experiences, and is also ill-equipped to understand how to make a diagnosis or provide treatment over time. Now, that's not to say that folks shouldn't be doing training and that folks shouldn't be entering this field, but it is to say that before folks set up a shingle and decide that they're going to ruin people's lives for 500 shekel an hour again, that they should work in a clinic such as the one that you run, or should work for a hospital, or should work for a rehabilitation facility, whatever it might be, where they are part of a team, have daily training and daily supervision, and ongoing academic trainings to learn how to do it. There's no substitute for experience.
Yeah, fundamentally, I second and agree with what Yaakov is saying, and especially that last point. You know, we've all done, hopefully all done the hard yards, spent time both in training and then both studies and the actual clinical experience that we get. That's certainly true with psychiatrists and for many mental health clinicians. I do think there's a slight difference and certain challenges that exist when collaborating with psychiatrists from the side of non-MD clinicians. The training itself is quite different. Yaakov and I have spent many hours, nights, months, years in emergency rooms dealing with, very acute situations and a mixture of both mental health and physical health, and where that interacts. And there's probably less familiarity in the general professional mental health community as should be, because we're not dealing with primarily physical illness, whereas in terms of training, it's something that as an MD we have to go through a lot of that training, and that will also color how we see certain situations as well. I think some of the challenges that we have, and I'm going to speak a little bit, not begnai in terms of to disparage as psychiatrists, but often the caseload scale is very, very different from what any other mental health clinicians are dealing with. So, whereas if you're thinking about a therapist who has a very significant caseload of, let's say, 40 cases that they're dealing with at any one time, that's a very heavy caseload, especially if you're dealing with complex clients. Psychiatrists will often be dealing with north of 1,000 patients at any given time. And so that does make it very hard for us when often, and I always feel guilty doing this, but I'll have, therapists that will reach out and say, can we just have a schmooze or a chat at some stage about this client? Now, this is a client that maybe I haven't seen in a best case scenario for 3 months, and I'm not due to see them for another 3 months, and having, a little chat, which is usually, 5, 10, 15, 20 minutes, is not an effective use of time, and ultimately doesn't make me effective as a clinician. So I need to write to the clinician and say, it's not personal. However, in order for me to remain effective, we really need to have written communication that I can refer back to and to look at. And so sometimes I get a little bit of kickback from that, but in most cases not. There are certain psychiatrists, as you point out, Zaki, that aren't particularly collaborative. They're not necessarily interested in, and we could say that, we're put at a disadvantage because the training that we go through, certainly within the hospital system, is that there's a very clear hierarchy. And that's something that we see where the doctors sit at the top of that hierarchy, whether we agree with it or not. That is the hierarchy. And you see that certain doctors will then say, well, why do I need to collaborate? I sit at the top of that pyramid and what I say goes. And that's just, you'll listen to what I say. I think that that's personally, I think it's wrong. Professionally, I think it's wrong, and it leads to worse outcomes. However, it's something that needs to be acknowledged that there will be certain psychiatrists that won't have a lot of time or interest to spend a whole lot of time on collaboration, especially if they're very time poor and they're used to working within the public system, and they really just almost feel like they're doing, a favor for the client, a favor for the clinician. They'll be writing prescriptions. I'll see you in 6 months, and that's it. It's your client. I'll do anything to do with with the medication. That's me. The rest of it is yours. That's not how we practice. That's why we, Machon Vir was set up very differently. And there are many, other professional frameworks that really do foster collaboration. But it's important to be aware that not every clinician, and that certainly holds true for psychiatrists, are necessarily going to be collaborative, and to be aware of that. Add a few more points, but I'll okay.
So if we were to just turn for a minute and make this tachlis, it sounds like, if let's say we ask the question, okay, on the clinician side, on the therapist side, what can we do to better foster collaboration? It sounds like you're both bringing up different points. It sounds like, Dr. Freedman, you're saying, well, first of all, be trained. If you're not trained, that makes it very difficult for us as psychiatrists to be able to work with you, and it's going to test our patience. We think it's dangerous. Okay, so let's assume for a second, though, that we're not irresponsibly in private practice. Let's say we are a beginner-ish clinician, but we're aware of our limits. And that's kind of like why we're also reaching out for support. Or let's say we are actually working at a clinic, and we do have that support. We're just not super experienced in this area, or maybe we're early career. It sounds like you're saying you started with stop collaborating and start listening. It sounds like what would make it easier on your end to collaborate with a clinician in that case would be if we have that awareness of our limits and we're willing to collaborate by being receptive to feedback. And where you encounter somebody who is kind of overconfident, that it's really frustrating and it detracts from collaboration. I'm curious if I got that right. On Dr. Harris, it sounds like you're saying you're coming from a more practical place. We've got many more, psychiatrists have many more patients than therapists do, see them less often. The information is less fresh in our mind. And so we need to be able to set that up in the way that's going to work. I hear you talk about written communication, and I hear what you're saying, and I'm on the receiving end of that also, because sometimes I'll ask you a question, and you're like, okay, Taki, can you email me? And I'm rolling my eyes and like, no. So sometimes where it's a quick question, that makes sense. Like, we can email a quick question, but sometimes it's not a quick question. Sometimes it's, hey, I want to troubleshoot this with you. Because there's like this question that I have, a conceptual question, a diagnostic question, and I want to work it out with you. What could we do on the clinical end that would better facilitate that? Short of there being a crisis where you're like, oh boy, we gotta actually speak.
So I just want to be medayek on something that Yaakov said. When Ice-T actually wrote that song, it was stop. Vanilla Ice, sorry, not I say thank you, Vanilla Ice, sorry. Stop, collaborate, and listen. It was all three things, okay? It's not a stira that stopped the collaboration and listen. It was collaborate and listen, okay? Just for the record, all right? It's a good part. Thank you. That might be the most important thing I tell you today, Yaakov. I think clear communication, and if there are specific ways, at least from the side of the psychiatrist, when I get, say, an initial someone reaches out, makes contact, says, let's have a chat. And I say, look, chats sound good, but let's communicate. Can we email? And then I get, a good conceptualization where there's clear questions. That really is very engaging as a psychiatrist, where I feel that I can be helpful and add on and to collaborate. One of the things that I find difficult and it's challenging, and Yaakov had actually hinted to this, is that as psychiatrists, we're often the ones that are left holding the baby or the buck stops with us, certainly in terms of risk management. And so that's something that we understand inherently. Something that can make it difficult as a psychiatrist is if there's an expectation from a therapist that, okay, I'm only reaching out to you in order to transfer liability over to you. And it's not really coming from a sense of clinical collaboration, but it's sort of medico-legally, I want to cover myself and I need you to be involved so I can do what I can do, but if stuff happens, it's going to be your responsibility. And that's something that can sometimes lead to a bit of resent on the side of the psychiatrist. We are very prepared to assume responsibility. It is something that we do, and it has to happen within the context of genuine collaboration. And also, that touches a little bit on people recognizing when they're, this is something which is beyond their clinical competency or experience. So for someone who's junior, I'm happy to work with anyone, regardless of seniority, as long as there's a certain, we should all have certain clinical modesty and insight into what it is that we're good at, which is often a reflection of what we like and what we're drawn to and what we read up about and what we skill ourselves up in by experience. So, that can be already a very junior clinician who recognizes certain limitations that they have, can already express certain interests that they have, but is clearly thinking about things and is, asking questions that is appropriate for where it is in their level of training. And that is actually very engaging as a psychiatrist because it's someone who you see really wants to grow, but also understands where they are. If it's coming from a position of someone who really doesn't have insight into what it is that they're dealing with, and there's an expectation that we're going to manage the case, that is one of the challenges in clinical collaboration that I've seen.
So I think that what you're going with is that if I love you and we have a relationship, then I'm grateful to collaborate with you and to be connected with you. And even that, if that means bailing you out, if you have a problem, I'll solve it. So, for example, if we have an ongoing relationship, make it easy for me. Let's be in ongoing communication, not just when there's a crisis, but whether it's daily, nightly, or yearly, we should be in ongoing communication to know about how people are doing on a regular basis. Send me a quick message that says, these are the 3 or 4 guys that we're collaborating on. They're doing good. This is the progress they're making. And do you have any questions about what's going on? That's easy. It's fun. We are a team when you make yourself a team member with me. As far as the people that I do work with, I would say that in general, all of them are vetted by my colleagues, whether at Amudim or at Relief. And in order to be vetted, you have to be somebody who has proper training, somebody who's receptive to feedback, somebody who has ongoing mentorship, supervision. And I think that that's a lovely service that our colleagues offer, Shmuel. A lot of new people come, and that's wonderful. A lot of people have started their career, and that's wonderful. But I know that, for example, Rabbi Katz will tell people, I'm not going to refer anybody to you until you've had your license for 5 years and you've had ongoing training as a general rule. I know that Yosi feels very strongly as well that people should have ongoing mentorship, ongoing training, and that they also keep track of who's easy to work with, who is not just going to bail on a tough case, but is rather going to take the achrayas for it. So I'm echoing a lot of your thoughts while also giving a karsatov to our colleagues who run these organizations, where a big part, frankly, I believe, of their work is not only vetting new clinicians, but also encouraging new clinicians to be the kind of people that they would want to work with. And I think that Rabbi Katz and Rabbi Yosi do a very good job of encouraging early career trainees to further their education in the field in order to make sure that one day they will be valuable members of the team.
Okay, thanks so much. I want to move on now to Rabbi Katz and to Yosi, where the collaboration looks a little bit different because your roles are different, I guess again drawing on my own experience as a therapist working with, let's say, case managers. So we've had some really amazing collaborations, some less amazing collaborations. And if I had to think off the top of my head on our end, what makes the difference, or to me at least personally, I guess it's similar to to what Dr. Freedman and Dr. Harris have been saying, that where I'm speaking to a case manager on the other end who wants to talk to me, and I need their help and they need my help, and we're kind of fleshing out ideas together and coming to a conclusion, then that tends to move it toward working well. But I've also had experiences where case managers kind of come in with an agenda and an idea of this is how it should be, and then it kind of doesn't work well, because then we can sometimes even have like treatment plans that are working in opposition, and that makes it a little tricky. So I'm curious to hear from your perspective, kind of working with a bunch of case managers, what's worked well in collaboration, what hasn't worked well, and then I'm also interested in hearing from Rabbi Katz in your dealings with therapists and throughout the vetting process. Where do you get a sense that, like, okay, this is somebody who we can work well with and collaborate well with, and where do you get the sense that it's not going to go?
Thank you. This is not rehearsed at all. We did have a general idea of the questions and the themes that were going to be going on. So I've been thinking about, okay, what sort of answers do I want to have prepared? And once you opened your mouth, I just went completely blank.
He's been working on that.
That's true. You've been preparing for a lot longer than I have. Yeah. So the truth is, a lot of what's already been said. Coming from the opposite side of things, coming from a different perspective. But so many of the points that have already been made, both by Dr. Harris, Dr. Freedman, as well as Yitzhaki, really it applies from our direction as well. I would say that one of the major points that I think are really integral to the collaboration is humility. And I say that equally from the case manager direction as well to the clinician. I certainly know exactly what circumstances that that Dr. Frieda is referring to in terms of, some cases go better than others, but humility is really very significant in terms of, I'll speak on Amudim's behalf, of what we're looking for with the case managers, that this isn't not to say anyone being meek or having any less confidence in their work, God forbid, but open to working with someone, open to being on a team, actually open to collaborating. Our experience, this may be oversimplifying, but has largely been binary. There are those that are open to it, and there are those who are not open to it. Also happy to say I think more people are open to it than not. But that really, I think, sums up a lot of it. It's like, okay, when you're open to it, fantastic, wonderful. We're able to have just honest, transparent conversations about what's going on from each direction, from each perspective as far as the clinical needs. And when you're working with someone who has that humility, who has that openness to work together, I feel like the answer's almost in the question. Like, great, smooth sailing. And when there is someone who is less open, and I'll only speak of my own experiences and my own intuition, that maybe it's a matter of a clinician who's less open of their own self-esteem, but feeling defensive, feeling territorial, not wanting to let anyone in. Okay, in my last thought, there's very little for the case manager to do in that scenario as far as that degree of that sort of collaboration. I'll be happy to share with Rabbi Katz.
So I really just echo what everybody's been saying. It's a lot of humility, being open to a lot of communication. You need to be open to communication, like Dr. Harris was saying, but it has to be in a format that's going to work. So, like he said, he's not going to always have time to sit down and schmooze about a case, but you start to learn the clinicians who you're working with, and what their style is, and who can give you time, who's not going to be able to give you time. But as a clinician, be aware of that, so that when you're communicating, you're doing it in a way that's going to work for the other clinicians, so that they will be open to collaborate. If you're going to try and collaborate with Dr. Freedman, you might. Good luck. He's a tremendous unav, and he has a very fragile ego. So you really need to be careful in how you talk to him. But once you know that, you can collaborate on a lot of cases, and you can learn a tremendous amount as a clinician, and be persistent. He's going to push you away in the beginning, and everything that you're seeing here is what you're going to get as a clinician trying to reach out, if not worse. But if you're consistent and you introduce yourself as, I've done this training, I'm this and this, and you try, you could break through the hard outer shell, and you will get something from him. There is right, there is what to be gained from it, and it's just learning about the other clinicians and their styles. And I think that to your second question, it's how do we pick which clinicians we're referring to? When we meet a clinician, it's not about, are we going to send to this person or not. It's who's going to benefit from meeting them, right? We could potentially send to anybody who is, as Dr. Freedman and Dr. Harris both said, trained in supervision, checking all the correct boxes as far as the clinical part. But as far as personality, it's really, we're thinking about who would we send to them, who could benefit from meeting them. So it's not like we're knocking anybody out because of how they performed in the interview. It's really about conceptualizing what we're going to send to them, and then it's feedback, right? Like you said, we get a lot of feedback from our callers about the clinicians and about what's going on in the room. We could pick up only so much through the meeting process and through our interview and our research, but it's really about the feedback from the clients. So obviously we understand that not all clients are going to be great reporters, but it's taking in all that information and putting it together so that when we're referring, we really do have a pretty good idea of what types of cases work for them, what types of personalities work for them, what doesn't, and what's going to work best.
I'm sorry, I just haven't monopolized the mic in a while. I think it's also okay on that point, just to bring up what you said. It's okay to have a bad case. We are not perfect, and it's okay also to have a difficult interaction. The reason I'm actually a bit surly today is because I got into an accident on the way in, so we should judge people favorably. I drove into a tree, and it wasn't my fault, though, because I had honked. And then my wife was actually giving me a hard time about it, which was unpleasant, until I reminded her that she had driven into a deer earlier this year. And, she said, well, that's not my fault. And I said, that was at the Gan HaChayot Tanachi. So, we're entitled to have bad days and bad moments and jokes that don't land. But it's important to maintain and build relationships. And the currency of a relationship is time. Are you a serious person that you want to be working together? If so, we'll be chasing after each other until we meet in the middle, because it's exciting to be on your team. I want to work with you. I want to collaborate with you. And I think we'll feel that on both sides. And again, you've created a model team. The program that you have at Mechon Devere is everything that it should be. It's people who have high quality training, who are in ongoing training together. It's a multidisciplinary team that's co-located, and meaning you can knock on somebody's door if there's an acute issue that has to be discussed, but there's just an easy flow of information back and forth. And I can only imagine how much it's improved now that Shmuel abandoned everybody to move to Ramat Beit Shemesh. Not that terrorist, rather the smug type.
Thanks, Yaakov. I want to actually touch on, just to run with something that Shlomo said, which is really important in terms of differing personalities and differing, matching up. It's almost like a shadchan service. You think about the relationship, certainly within therapy with the clinician and client, in terms of getting that dynamic right. And despite what many people think, Yaakov and I are not identical twins, and we have different personalities. And I think that really touches on something with regards to collaboration. Baruch Hashem, it's a very big world out there. The need for mental health is enormous. And even with everyone sitting in here, we all know that there's no way that we can possibly meet the need because we are limited in terms of the time that we have and the amount of clients that we can take on. And in a sense, that really allows us to develop areas of clinical interest and expertise. It's going to be guided by what we're naturally interested in. I remember actually probably the first client that I had at Hadassah when I was doing my training, who was a very clear borderline personality disorder, and no other training clinician wanted to go anywhere near her. And for me, it was absolutely fascinating. And it was something that, for whatever reason, I very much was challenged by and enjoyed working with. And so that allowed me to develop, a comfort and an expertise in dealing with this clinical population. And I think that collaboration comes out when we realize that with our colleagues, we're not in competition. We're actually there to support each other and to recognize, when a particular case is actually not a case for me necessarily, but I know exactly who it is for. And I can, recount numerous cases, for instance, that I've sent to Yaakov and that Yaakov sent to me, where it was obvious to both of us that the other one should have actually been managing this case. And kachaya, and that continues until today. And so I think one of the secrets of really good clinical collaboration touches on probably the most important point that was mentioned here today by Yosi in terms of humility and clinical humility, which is not born out of being meek and a lack of confidence, quite the opposite. True humility is when you know your worth, you know what it is that you're good at, and you also know what you're less good at or what someone else is particularly good at. And that then allows you to be excellent in your particular area, and you're not threatened at all by anyone else. On the contrary, you will look for other colleagues who you know are the right address for this particular case. And I think that is a secret to being a good clinician and being a good collaborator.
Okay, so when I'm kind of taking in what everyone's saying, I love the points that everyone's making. And it sounds like if we drill down, to okay, what's the takeaway? It sounds like everybody's coming to this same point, which is that good collaboration starts when I guess just we as clinicians, I'll apply it to myself, are first and foremost just open to listening and hearing the other side. And it's funny because this is just it's a therapeutic concept, right? This is something that happens all the time in the therapy room where we first and foremost have to be open to listening to our clients. And I'm just thinking about something that what might sometimes get in the way of that is that sometimes collaboration is just done on an ongoing basis just from the get-go, right? Like we do at Machon Dvir. But sometimes collaboration happens when we're stuck, we're in a crisis, and okay, I need your help. And once I'm already there, I've already got this built-up relationship with this client for a while. I have an idea of where I think therapy should go, and especially when there's a crisis, emotions are high, I get stuck in that, and that makes me more closed-minded to hearing something else. It's sort of like, okay, I need your help, and here's what I need you to do. And then on the other end, it's like, well, you're not listening to me, and then that's where things can get stuck. So I think the takeaway for us as therapists at least might be to regulate ourselves and to open first. I guess it all comes down to DBT, right? Emotion regulation and dialectics. I'm a nerd in that way. I'm sorry. I would love to open it up at this point to questions from the Olam here, if anybody has.
Yeah. One tiny thing onto what you said now.
If it's tiny.
It's tiny. When you're caught. When you're dealing with an emergency situation where you need help now, that is definitely made much easier and facilitated by a pre-existing relationship. So to expect that that's going to happen, to reach out to someone that you've never been in touch with before and say, I need you to help me now, is a much more difficult ask than, and Yaakov referenced this as well, when there's this ongoing back and forth and updates and whatnot, even when, and specifically when there isn't a crisis, then allows us to be more effective in collaboration when there is a crisis.
Thanks.
Thank you. And my point that I would like to add and see how do you think is that not only how to collaborate, but why to collaborate. So as a clinical psychologist, my point of view is that we collaborate because medication and therapy have a learning, both have a learning factor for us, therapists, for you, medical doctors, and for the patient. So I will try to communicate, and it went very well with you and also with you, but I'm sure you don't remember. What? Yeah, well, you do remember. Thank you. Wow, what an honor. So it's about this learning factor, which is not only when the patient is in a crisis, and sometimes the opposite, when he's going well, and know what is the medication doing. So he's going well, it's time to lower the medication, to raise the medication. For me, is the medication or is something that I'm doing well or not? I'm lacking something that I must do. So it's about the learning factor for me, for you, and for the patient. So this is.
Thank you. Anybody else? Any questions?
I'm the only psychiatrist not on the panel, so I figured I would ask a question. Hi. What, in your experiences, do you feel would be an appropriate or good response, or how do you handle situations where patients will come in and describe splitting very negatively towards their therapist who you have not spoken with or seen? And how do you navigate validating that without offending the therapist and working back and forth collaboratively with them?
Wow, I feel like that could be a panel in and of itself, just that question. I know.
Splitting is something that we deal a lot with and face a lot with at Machon Dvir. It often, is quite common, especially within a borderline pathology as well. And it's important to, as well, hold this sort of balance between validating and showing the client that you're listening to what it is that they're experiencing. If you haven't worked yourself out enough as a clinician, you can very easily play into that split, especially if you're on the idealized side of the split, as opposed to the devalued. And especially if it's, some therapist you really don't like. Oh yeah, they're bad. But hopefully you're a little bit more professional than that, and to sort of reflect back. And a lot of splitting can actually be dealt with, especially if there's a pre-existing relationship. And this is a therapist who I know and have worked with. And then, part of the way, at least, that's part of the reason, actually, why at least we set up Machon Dvir for this type of population, because it's so important to work closely together as an integrated team. Now, there are many clinicians that I work with outside of Machon Dvir, and that becomes even more important to make sure that there's good collaboration between various therapists and certainly the psychiatrist and the therapist as well, so that we're not playing into that split, and ultimately it's just going to lead to a worse clinical outcome for the client. So it really comes back again to good communication between clinicians, being validating, but also trying to hold a bit of that dialectic when you're dealing with someone who's very clearly splitting, and even being aware that a split's going on. Because if you're unaware of that, you don't have insight into what's actually happening in the dynamic, then you can end up causing a lot more damage. And especially if there's no real communication with the other therapist, and then just playing into that split.
Yaakov. I love the question. I immediately overwhelmed with examples of, even just with Machon Dvir alone, of where working with an Amudim case manager, and sometimes the split is obvious and it's on the surface surfaces of everything, and sometimes neither party is even aware that a splitting is going on, and just organically and naturally through a healthy, established collaborative experience with the case manager and whichever treating clinician in Machon Dvir, where it comes to light, and it's like, oh, good thing we're collaborating now. And I think that the secret in terms of when faced with this sort of split is really just on top of what Shmuel was saying, is just like really this that communication, like owning it, defining it, saying it out loud, giving it a name. Everyone needs to be on the same page, including the client. It doesn't need to be a disciplinary sort of process or experience, but like presumably in this situation, there's ROIs, there's consent for everyone to be speaking with each other, of course. And when you have that team working with the client together, the client deserves and should have just as a transparent experience as we're calling for between the clinicians.
How did you guys pick your outfit? I thought the generals used to wear green. Right, Harlem Globetrotters. You guys are all white guys with glasses, wearing checkered shirts. You too.
Okay, I think, yeah, I don't know how we come up with the same shirts all the time. I don't know. Anyway.
He's not in the way.
I guess going back to the splitting question, I think ultimately it all comes down to this same idea of humility, right? I don't have the full picture. I just have part of the picture. And my relationship with this particular client is going to be very different than your relationship with this particular client. The client is not lying. The client is being really honest about their experience of us, and we're being honest about our experience of the client. They're just different experiences. And I think that when we can honor that, and we can understand that, and we can approach the conversation that it's not that one or the other of us are right. We're actually both right. This is what's happening. Given that, what would be the best way to go about it? That in our experience is the best way to resolve it. But when we kind of get stuck and we think that like, yeah, this is the correct perspective and they've got it wrong, then it just all falls apart and it gets really tough. We're at time. I want to just remind everybody again about the QR codes for that last session where we can take more questions and go more into depth. Just scan the QR code and put your question in, and we'll get to it at the last session. I want to thank everybody for participating, all you guys. Sorry about the accident. I hope the tree is okay. And I don't know everything. He could. Yeah. I don't know which one is more believable.